So at this ASH meeting, I have the opportunity also to update our data set from our investigator-initiated clinical trial of Acalabrutinib, Venetoclax, Obinutuzumab, or AVO, for the frontline treatment of CLL. This is a study that we presented some very early data on last year, and really the rationale here is that we have very effective frontline treatments for CLL with Venetoclax, Obinutuzumab, and Acalabrutinib, Obinutuzumab, and we wanted to evaluate the safety and efficacy of a combination of Acalabrutinib, Venetoclax, and Obinutuzumab. The first cohort of the study, which we presented on last year, was all comers, and we continue to follow those patients with longer-term follow-up. But in this presentation, we also begin to report on some early outcomes for patients on a new cohort that specifically is looking at patients with deletion 17p or TP53 mutated CLL, in other words, high-risk disease. As a reminder, this is about a 15-month combination regimen, and if patients have undetectable MRD at that point, they can stop therapy. If they don't, they can continue on to receive about 2 years of therapy, and they can stop therapy at that point if they're in an undetectable MRD state. So at this point, we are reporting on 44 patients. The study is certainly enriched for patients with TP53 aberrant disease. Close to 40% of the patients had that high-risk status, and about 66% have unmutated IGHV. The safety data, I think, look excellent for this triplet combination. That's certainly something we watch closely when we put 3 drugs together, but we're seeing grade 3 or higher neutropenia only in about a third of patients. And the rate of infections has been particularly low at this regimen. We've only had 1 grade 3 or higher infection in these 44 patients, with a median follow-up now of over a year and a half. The rates of atrial fibrillation have also been low, just 1 patient, 2%, and that was in a postoperative setting. We've not seen any grade 3 or higher hypertension or major bleeding issues, and we were able to very effectively reduce the risk of tumor lysis syndrome such that we have not seen any TLS due to Venetoclax on this study. Now, this combination has really translated also into a highly efficacious approach. So particularly as we look at the MRD undetectability rates at the cycle 16 evaluation, so after that 15 months of initial therapy, we see that 77% of the patients are undetectable for MRD in the bone marrow, 84% in the peripheral blood, suggesting very deep responses, and many of these patients have been able to discontinue therapy and go on to observation. And at this point, we have not yet had any progression events or even conversions to MRD detectability, although the follow-up for those patients is quite short right now. So kind of putting it all together, we're very excited about this early data still from the AVO study. The regimen seems to be well tolerated, highly active. We're not seeing tumor lysis syndrome. And we're seeing equivalent activity in the high-risk patients so far, those with TP53 aberration, as compared with the general population. So in terms of next steps for AVO, this is actually a regimen that's part of a randomized phase 3 trial that is ongoing, the CL311 study, comparing AVO to the doublet of AV versus chemoimmunotherapy. So I think that's an important and potentially practice-changing study. It's going to help answer a lot of questions about how these regimens compare to chemoimmunotherapy, whether we need the Obinutuzumab in a triplet or whether a doublet may be sufficient. And I think that's the type of study that really has the potential to change our practice.